Good evening, everyone. This is Hussain Ghadiali, and I will be your host for this evening. Welcome to this webinar series, Advances in Neuroimaging. Our topic for the day is brain adiposity as a biomarker for Alzheimer's spectrum diseases. This webinar is put together by In-Med Prognostics Team NeuroShield in conjunction with GE Healthcare. And on their behalf, I warmly welcome you today. Without further ado, let me introduce Dr. Girish Srinivasan, our speaker for the day. Dr. Girish Srinivasan is based in Chicago and has 20+ years of experience in medical technology solutions. He holds an MS in computer science and artificial intelligence and a PhD in biomedical engineering, with leadership roles in R&D, product strategy, clinical research, and marketing at Toshiba, GE Healthcare, and Samsung Healthcare. His areas of research focus on involving digital phenotyping for precision healthcare through integration of autonomous solutions and artificial intelligence technologies. Our panelist for the day is Dr. Ram Mohan Valapari, with an astounding clinical radiology experience of 33+ years, senior consultant radiologist with Global Digital Innovations, GE Healthcare. He's a doctor in medicine radiology and a PhD scholar in neuroimaging. Author of 6 books in imaging and a senior consultant in radiologist at Vijay Diagnostics, Hyderabad. Before we start, a couple of things to note. All participants will remain muted during the presentation, and we would request you to add their questions to the chat box. They will be addressed by Dr. Girish and our panelist, Dr. Ram Mohan Valapari, at the end of the presentation.
Hello, I'm Dr. Girish Srinivasan. I serve as the CTO for In-Med Prognostics. I'm also the co-founder and CTO of PMX, a partner company with its offices in Seoul, South Korea, and Chicago, USA. I'm going to be discussing about a multi-parametric approach to identify novel biomarkers for early identification of cognitive decline that may lead to Alzheimer's disease. In 2012, the Alzheimer's Association and National Institute of Aging declared that Alzheimer's is not a single disease, but a spectrum disorder. This means that any clinical presentation, signs, and symptoms have significant variability. This also means that appropriate biomarkers are critical in identifying the disease pathway and thereby any intervention. Let's take a look at a short video that describes the most researched pathway, the plaque deposit. Recent findings and research have raised major questions regarding the validity of plaque as a cause of Alzheimer's disease. The FDA very recently granted approval for an Alzheimer's drug targeting the plaque. If you did not believe in the existence of any controversy, just a couple days after the approval of the drug, members of the FDA expert panel resigned to show their lack of approval. For people who did not join the previous CME hosted by In-Med and GE, Dr. Kulkarni, a neurologist from Dinanath Mangeshkar Hospital, discussed the role of MRI and volumetric measurement in neurological disease such as Alzheimer's. I highly recommend you to check that out. Research and clinical evidence has shown that there are observable structural changes in different subregions of the brain across Alzheimer's disease spectrum, which includes mild cognitive impairment. Some regions, such as the hippocampus, show significant atrophy on patients compared to healthy control. Although just structural measurements may be valuable, atrophy is not apparent until later stage of the disease. This poses challenges in early identification of cognitive decline, which may lead to Alzheimer's disease. Now let's switch to a completely different thought. Does obesity have any relationship with any form of dementia, including Alzheimer's dementia? Various recent studies have shown that obesity, or more specifically adiposity, may increase the risk of Alzheimer's disease even in people who do not have any family history or genetic predisposition. The first thing that I did when I learned about this finding is to go check my BMI. So, is BMI a good marker? More than just the BMI, the body composition may be more relevant here. Body composition is simply assessing the distribution of different tissue types such as fat, muscle, etc. through the body. Body composition measurement can be achieved through simple solutions such as a cell phone camera or a more advanced weighing scale, a 3D body camera, a DEXA scanner, and a CT or MRI machine as well. But the gold standard for highly specific body composition measurement is through MRI and MR spectroscopy. The picture shows a whole body scan with spectroscopy-based metabolite distribution across specific slices. So now let's connect the concept of Alzheimer's disease and body composition. Does this mean that in order to use body composition as a potential marker to evaluate cognitive decline, we will need people to go into whole body MRI scans? To check your brain, we will scan your entire body for 1 hour and charge you a few $1,000s. Seems like a tough sell, right? Is there a better way to make the most out of imaging? In 2016, a paper from Wake Forest Health looked into and demonstrated the ability of using standard clinical head MRI to estimate body composition. They used 3D T1 weighted brain scans to measure fat and showed that it correlates well with abdominal fat, which has been proven to be a good indicator of overall body fat. A typical neuroprotocol for Alzheimer's disease evaluation for patients include a 3D T1 weighted sequence, amongst others, which can be reliably completed in about 6.5 minutes. Can this be a single golden MRI sequence for measuring brain volume and body fat? To understand this, we did a retrospective study. From the Alzheimer's disease neuroinitiative data, 100 subjects with 3D T1 weighted MRI were identified, each for control normal, stable MCI, progressive MCI, and Alzheimer's disease groups. Volumetric quantification of gray matter, white matter, CSF, hippocampi, and lateral ventricle were performed using ensemble machine learning algorithms. Quantitative fat segmentation was accomplished through thresholding of high T1 fat signal intensity. All of these parameters was then fed into a random forest diagnosis classifier. The results? The image shows a region of fat on a sample slice. Independently, the head fat percentage showed a statistically significant difference between the diagnosis groups as shown in this chart. These are the classification accuracies between the diagnostic groups when using the different parameters. One particular point to note here is the classification accuracy between stable MCI and progressive MCI, which is a clinically relevant distinction to be made. And this improved from 62.6% to about 64.3% when the head fat percentage was added to the volumetric measurement. The trained classifier was then tested on an independent 168 subject dataset from a single clinical site. The head fat percentage showed even greater effect size on predicting diagnosis compared to the previous ADNI data, suggesting that there is good generalizability of the classifier. This study was conducted by the PMX team from South Korea and Chicago in collaboration with Wake Forest Health, which is in North Carolina, and the Konkuk University in Seoul, South Korea. Lastly, a final word of caution. Being a couch potato will not only lead to increasing body size, but also decrease in brain size. Thank you very much.
Before we move to the Q&A session, we have a short video on NeuroShield, which we would like to present.
How often do you use your brain? At this question most people chuckle or laugh. But the fact is we all use our brains all the time. Have you ever thought of your brain's health proactively? Almost never. Part of the reason is because we don't have reliable tools which will help us manage our brain's health. So, we at NeuroShield have come up with a solution where we offer cloud-based clinical decision support tool for neurological disorders. NeuroShield is an artificial intelligence and machine learning-based tool helps neuroradiologists, neurophysicians and psychiatrists understand the brain better and offer evidence-based diagnostics. The current challenges, which are operational and clinical problems. All the existing solutions addressing these problems are expensive, time-consuming and don't provide contextual results based on age, ethnicity and gender. NeuroShield, our solution, which combines the latest tools in medical and technological advancements. The common practice for doctors is to perform a neuropsychological assessment and ask for an MRI to help in diagnosing brain degenerative diseases like epilepsy and dementia. But visual MRI reading can many times provide non-conclusive information, resulting in misdiagnosis. Our software, NeuroShield, makes it possible to look clearly at the region of interest, like hippocampus, compute brain volumes, and supported by cutting-edge research and imaging analytics, which can help physicians reach more reliable and conclusive diagnoses as opposed to the conventional method. NeuroShield is the platform that aggregates insights from relevant modalities to provide holistic health and wellness insights. These are some snapshots of the platform provided with the test reports and volumetric analysis. Our competitive advantage matrix are as follows. Our vision is to bring affordable, accessible, reliable and evidence-based health prognostic tools in India and other emerging markets. Reach out to us and get to know more.
Yeah. Hi. That was an awesome presentation, Mr. Girish. This is Dr. Ram here.
Thank you, Dr. Ram.
Thank you very much for introducing us to the brain adiposity or the adiposity, whole body adiposity, which is an indirect or a contributory biomarker for neurodegeneration or to be specific, AD related dementia or the AD spectrum disorder. My experience with adiposity evaluation using MR has been since last 8 to 10 years, specifically for body fat evaluation. And for evaluation of intramyocellular lipids and extramyocellular lipids, also in the peripheral soft tissues, that is in the calf muscles, to look at various inflammatory myopathies or inclusion body myositis or the lipid metabolism using hydrogen spectroscopy. So the dirty cat versus vat tissue or a cat or a adipose tissue is the very, very important parameter. And it is not the amount of fat, it's the quality of fat. It is a dirty fat, what they say. So because of any infection, inflammation, or any dysfunction can disturb your distribution of fat and cause a lipodystrophy. Example, in HIV patients, you see there's a lipodystrophy, and same patient may have HIV dementia. So there is definitely a unmatched or unmet need for looking at various important common biomarkers, which are actually related to the regular lifestyle index to predict dementias. So the floor is open for questions. This is very creative talk, and this has a tremendous amount of scope because we have apple people and pear people as far as abdomen configuration is concerned. We have owls and larks as far as the sleep patterns are concerned. We have BMIs and BMWs as far as body configuration are concerned. So we have definitely a lifestyle parameter here, and adiposity is a systemic issue. And looking at scalp fat and the neck fat and on the existing head and neck MR as an additional biomarker to a dementia protocol is a fantastic approach. So I would now the floor is open for questions. Feel free to ask, and we have an expert, Mr. Girish, the phenomics of the brain and adiposity of the brain. Ladies and gentlemen, please ask the questions and put them in the chat box. And Hussein, if you can look at the chat box, please articulate the questions. Yeah.
Is MRI data casually related to the body composition or just statistically related? Is the first question.
Yeah, so I'm not exactly sure about, what is the intent of the question here. There is general casual overall evidence that there is a relationship. That is, people who are obese are known to be having a higher risk of Alzheimer's disease. And I think there has not been a large amount of studies there has been some amount of studies, but more in the recent, I would say, that is starting to prove this out in various mechanisms and various factors. And as Dr. Ram rightly pointed out, the aspect of just not just general obesity, but it's more about insulin sensitivity, higher fat deposition, visceral fat, and where it's accumulated. All of these form important contributing factor to the inflammation that happens in the body. And I think inflammation is one of the primary causes of many chronic conditions, including Alzheimer's disease. So I think there is an overall accepted or defined knowledge that obesity does have a relationship, and hence the best way to understand and measure obesity, in my mind at least, is body composition estimation, because getting on a scale or doing simple measurements, although can provide an early assessment or a simplistic viewpoint of what's going on. It is the actual distribution that makes a difference, and specifically looking at visceral fat that is inside and around the organs are the ones that cause the problem. Statistical proofs are starting to emerge, and I think MR is an excellent non-invasive, non-radiation tool to do a very specific, highly sensitive, highly specific measurement of adiposity, and that's the reason. I think that's I think a roundabout answer, but yeah, I think that's what I feel.
Yeah, one of the indirect evidences that fat could be an inflammatory agent is our non-alcoholic hepatosteatosis or steatohepatosis, NASH or NAFLD. People with fatty liver who are non-alcoholics can get cirrhosis, right? So fat is your friend as far as imaging is concerned, because fat will show interfaces and fat will show good signal on MR. At the same time, absent fat or inflamed fat would be a good biomarker in other conditions. But the question which was asked was that is it causally related or statistically related? The box plots, what he has shown in the MCI definitely shows that there is some kind of significant statistical difference. Am I right, Girish?
Absolutely,
the only
Dr.
interesting
Ram.
part, the only interesting part of this question, I think, is the epicenter of the fat. Is that if the where should we look for fat, which can be the deterministic biomarker for Alzheimer's? That could be the future, question what we need to ask.
Yeah, I think that's an interesting point that you bring up, Dr. Ram, because I think that one of the motivation of this study was actually derived from the 2016 paper that I had shown, which actually showed, I mean, typically body fat and overall body fat estimation is done using abdominal fat, and CT has been one of the most common modalities to do that. And you can do almost a very single slice between the L3, L4 spine and estimate fat just by that single slice. So this study was actually attempted to correlate the estimation and measurement of head fat with the abdominal fat, specifically in CT and MR. So that's the only current mechanism that has been established or at least sort of studied and looked out for. But absolutely right, as you said, I think what is the region of fat and from the overall body that correlates most and relates most to the general fat in the body, plus also correlations with Alzheimer's, is a potential study to be made in the future.
Yes. Hussein?
Yes. Another question, is there any relation between muscle atrophy and Alzheimer's disease?
I think interesting question. There has been, again, some minimal studies that I have come across where I think it's cachexia. It's basically more from oncological correlations. There has definitely been indications of wasting of muscles in cancer patients, as well as people who are undergoing radiation treatment. And this is actually a concern. A disease such as sarcopenia and stuff like that have had problems of muscle wasting, and because of that, the rehabilitation of people and rendering them very difficult to have a day-to-day normal life. And so even if people are suffering from cancer, I think cancer-based cachexia and muscle wasting is a much more severe problem. And according to, if you're able to find out and predict the muscle wasting patterns, then medications and interventions as well as nutritional supplements can be facilitated and supported. But again, that I'm still not answering your question of whether there is relationship with Alzheimer's, but I think I probably have not seen too many specifically in Alzheimer's. I'll leave it to Dr. Ram for that.
Yeah, I think this is a question which has a lot of depth, in the sense that the disuse atrophy, if you are like you are undergoing rehab, or you are bedridden, you are debilitated, your movement is restricted, and your mental health zone is challenging. That's why you are not asked to move out. So obviously there are incidences where you can get disuse atrophy in people, but unlike ALS and other neurodegenerative conditions, the dementia can be associated with it, but not dementia is not a cause of muscle atrophy, because there is a lot of complex spectrum of these neurodegenerative conditions which manifest with dementia and other abnormal movements and neurodegeneration related atrophy. I hope that answers your question, but there is no direct association, but there could be association between dementia and atrophy. Yeah, regarding Aarti says she's working on degenerated, yes, she's working on Shiatic Neuropathies, which is my favorite topic. So sciatica, the nerves, people in general who are not mobile, are not active, and who are bedridden, or who are in the ICU, or who are having motor dysfunction or whatever it is, they are in the lying position, supine position, so they can have ischiofemoral impingement or compression on the sciatic nerve at the ischiofemoral tunnel or at the bony compression points, and they can get compressive sciatic neuropathy. In fact, I've seen many patients, and patients come with a foot drop or some kind of things, which is because of chronic repetitive compression, and patient is not active like other active members. So sciatica directly related to dementia, this could be the reason. Yeah. I think Aarti, are you happy, or just answer in the chat box, or we can discuss about it in detail.
Yeah, I have unmuted you, Dr. Aarti. Yes.
Dr. Aarti, you can ask me the question.
Hello.
Okay,
Hello?
you are, yeah. Okay, you are okay with my answer?
Good evening, sir. Yes, sir. Yes.
Yes. So I know that in Dinanath Mangeshkar, they do a lot of good neurography. Because I regularly do sciatic MR neurography. We see different kinds of patterns, and patients with COVID now who are admitted in the hospitals for days together come out with a foot drop. So has COVID caused this, or the lying position for a long standing situation where there is atrophy, or where there is catabolism, or patients with burns, or who are admitted. So all these people where fat suddenly vanishes, either fat accumulates or fat vanishes. So the cushion effect between the nerve and the bones, and the nerve and the surrounding tissues is gone, or any minor injury like an injection or a compression or a small, positional kind of mechanical injury can cause, sciatic neuropathy.
We have another question. Does fetal excessive general body adiposity born to diabetic mothers have any long-term effect on brain adiposity? Does it have any role to play in future degenerative brain disorders for the child? Let me repeat that.
Understand the question.
Yeah, I'll just repeat that for our attendees. Does fetal excessive general body adiposity of the child born to a diabetic mother have any long-term effects on brain adiposity? And does it have any role to play in the future for the child as far as degenerative brain disorders are concerned? Thank you.
That means it is a womb to tomb journey. Okay. So it is a womb to tomb kind of longitudinal study somebody has to do. So the fetal macrosomia due to diabetic, who are born to diabetic mothers, have excessive adiposity, and then may develop insulin resistance and may become diabetic or further. But I don't know. I don't have the answer for that unless somebody does a study, because it is only by evidence-based study that will answer the question.
And I think there are I have come across a couple of studies which have shown some correlation, that is in mothers with sort of chronic diabetic conditions where there has been the presence of general body adiposity the
that part I agree. Girish,
Yeah.
that part I am sure. The fetal macrosomia in diabetic mothers, adiposity is known.
Right.
But what they are asking is, what is the prediction value of this fetal adiposity to the neurodegeneration when the child grows up, which is a very big womb to tomb journey, right?
Yeah, it's a huge one. Yeah, right.
Yeah, huge one. So I don't know any longitudinal study which has done that.
No, I definitely don't think so. But I think what it calls for, I think it's interesting, and as MR as a modality, right? It's a because of its potential non-ionizing, non-invasive solution, it actually can serve as a good tool, as a screening tool, even for younger individuals to go in and get a, I think personally my vision is you walk down the road, get a quick scan. It sort of gives you a overall health status report. It's almost like having a pharmacy going and taking your blood pressure. It's become that common today. I do envision a future where you can do this at a scan level, but I think I think the question sort of leads me to think that if you would like to have such longitudinal mechanisms of understanding, and exactly Dr. Ram said, it's a womb to tomb story, and you need to track yourselves as early as possible. So I think that there is possibility, and if the scanners are becoming more accessible today, so I think that ability to do more of longitudinal assessment would hopefully come down to reality in the future.
I think the brown fat, the brown fat has also some kind of role which we need to investigate, because because we still don't know about fat, and brown fat shows PET uptake when we do whole body PET scans, and confuses as if it's abnormality, and normally should get involuted, but in some people it persists, right, due to genetic dysfunction. So anyway, I think there seems to be another question, Hussein from Jayaprakash.
I have unmuted you, Dr. Jay, if you'd like to interact with the panelists. Okay. So,
hello.
Yeah.
Sir, actually, I wanted to know, what is the real mechanism of the role of brain adipose tissue with respect to degenerative disorder? What is the mechanism? How does the quantification really help? What is the real biochemical mechanism? Hello.
Yes, Mr. Jayaprakash. I think that's certainly a very deep question. Again, I think there's a lot of I'm definitely not the right person to answer it. My role has been primarily to measure, because of the known relationship between body adiposity and its how it serves as a marker, and people, it's more of a causation correlation reaction where it's not a causation. People who have a higher amount of adiposity have shown to be at a higher risk of Alzheimer's, and the point that I was trying to convey here is the fact that in order to reliably measure the adiposity, do you really have to go and do a more of an elaborate body scan, or can this be something that can be obtained, or can this be something that you can reliably obtain from a brain scan? Now,
my specific question is, sir.
Yeah, understand, Jayaprakash. What you asked is it an association or is it a cause?
Yeah, I got it, sir. You are telling it's an association, like.
No. I don't see. I am not an expert in this, but what I'm saying is, it is your question is that what is the pathophysiology? How can an excessive fat
correct. That is it.
can cause? I'm not sure about the answer. We need to figure it out. Yeah. Because how can the microglial activation in the brain will be related to the fat?
No, my one curious does the fat really interact with these amyloid plaques, and does it cause any interaction with these plaques?
So from what I understand, the plaques are basically mechanisms by the brain to to sort of the brain cells die because of inflammation, and when the brain cells to stop the brain cells from dying, these proteins which actually get the amyloid proteins that get deposited in the brain, for it to not be impacting the brain cells, the brain actually stores away, it sort of clumps them together and tries to eliminate them from the brain in order to make sure that it does not cause the brain cell death. And this is, so the clearance of the beta amyloid plaque is known to be done during sleep. And this is why I think the sleep is becoming an important measure. Now, when the clearance does not happen, there is accumulation of the amyloid plaque, and that is pretty high when people, and it leads to Alzheimer's disease. There is more recently, it is being shown that beta amyloid plaque is not the true cause. And this is why the controversy that I initially talked about, that it's not the real underlying cause of Alzheimer's disease, but it's actually a brain's body's mechanisms to cope with these buildup of the beta amyloid plaques. So the real target is to try to reduce the amount of amyloid proteins that get accumulated in the brain. Now, so that's the reaction that goes on today. Whether fat has a role to play here is again yet to be seen. I don't have that answer specifically.
I think I have some vantage point here, Girish, is that people who don't sleep properly, okay, who circadian rhythm disorders, who have late night sleeps and a few hours of pendulum, these guys, we have seen them that despite the best anti-obesity measures they take, that they don't lose weight, number one. Number two, their growth hormone is active even when they are, because they don't have a good sleep. So whenever you don't have a good sleep, your growth hormone is still active. So you are, because of circadian rhythm and your cortisol is acting, so you will, you won't have a proper sleep. So sleep is always related to adult ADHD, people who come with a little bit of snoring, people who have sleep disorders, they have huge obesity issues, and also they have ADHD or adult ADHD issues. So somewhere these are all linked together. So we need to do a multi-parametric, as you rightly mentioned, a multi-modality and multi-parametric studies, and study the outcomes. This is a stimulation. Your presentation is a real stimulation. Because in this present scenario, we cannot dispute any out-of-the-box thought process unless it is proved. Right? Like in Harvard, they say that if your hypothesis doesn't match the existing theory, please be aggressive enough to disprove the theory.
Yeah.
Okay. Thank you, sir. Thank you. Thank you.
Right, sir. Yeah, Buresh.
And I would like to add that at the frontier of science, when there are more questions that need answering, it's true that we're making progress. So thank you so much, Dr. Girish and Dr. Valapari. Another question that we have is, can nuclear medicine studies play a role in volumetric analysis in these areas? And how can we improvise?
improvise. Now all the volumetric scans for neurodegeneration, dementia, movement disorders are usually combined or co-registered with PET CTs. Or the MR data is co-registered with PET. The area which is atrophied, they are selectively atrophied or abnormally atrophied. It also shows hypometabolism with preservation of normal metabolism in some other areas. So each disease has a signature based on the metabolism activity or hypometabolism or normal metabolism with atrophy patterns. So atrophy patterns with region-specific combination is a signature of example. If a patient's precuneus is atrophy, and immediately people say, "Oh, is it DLBD? Is it posterior parietal variant of Alzheimer's disease?" So when we do PET CT and combine the MR and PET, definitely nuclear medicine is a part of evaluation, and also while NeuroShields second version is coming with the PET fusion also. So it is definitely one of the decision maker in the diagnosis and diagnostic pathways, because metabolic dysfunction is a proof that a particular area is preserved metabolism, like the cingulate island sign, where the cingulate metabolism is showing abnormal in DLBD versus posterior variant of Alzheimer's disease. So we have differentiations of different subtypes and clinical phenotypes of dementia using a combination of volumetry and clinical clinical symptom checkers like visual hallucinations in DLBD versus visuospatial disorientation in Alzheimer's. So we need to have a multi-parametric, multi-modality approach. So a very important question you asked. It is a part of the game. There's nothing else to improvise. It's a part of the package that PET is combined for decision making. Because as a clinician, we need to have holistic solutions. Unfortunately, holistic solutions are not available on the dashboard due to multiple reasons. But so the day is coming that one-stop shop solutions or disease-specific solutions are available, so that you can take at the first instance itself as a comprehensive study and protocol. So that will also minimize the cost, and it may temporarily increase the cost, but it will minimize the longer time cost effective down the road. And also it will increase the number of biomarkers for confidence level. And also for comparison of disease burden before treatment, after treatment, or for follow-up. It's very important that multiple modalities of studies. And according to me, nuclear medicine is backbone, and which has to be studied with the coexisting data. And very nice question, sir.
Dr. Shweta, would you like to add something?
Yes, hi. Thank you for the fantastic talk. I just had a couple of points based on obesity, the previous topic which was going on. I think it's very clear that obesity is the inducer of inflammation, and obesity itself is an inflammatory disease. Now, talking about the amyloid, whenever there is a metabolism and inflammation issues, we have already seen that AAA proteins are quite common in people with metabolic syndrome. And the same thing is being found on people with dementia. So SAA3 and many other proteins are actually part of myelin sheath and underlying neurons, where the whole cascade of inflammation actually begins. And then the whole thing sort of goes down, and we see what we are seeing in Alzheimer's dementia. So the starting point as well as the multiple steps is all linked to this inflammatory biomarkers due to obesity. That's just the point that I had. Thank you.
Thank you, Dr. Shweta. That's really insightful. Very useful information there to add.
Yeah, I think she highlighted the importance of the cascade.
Exactly. Right.
And what is the velocity of the cascade? It is case sensitive and individual specific. Why in some people they have huge amount of fatty liver or obesity, they don't get cirrhosis or NASH? Why some people get it? These are all the triggering points where we need to measure them with longitudinal studies. Thank you very much for the comments, Dr. Sweta.
Thank you, Dr. Shweta and Dr. Valapari. So another question, how effective is Aduhelm in treatment of Alzheimer's? Dr. Girish has answered it in the chat. I would like to bring it up to the forum.
I do have. I was actually. I think I saw that the approval came through from It's a the drug approved. It's a drug from Biogen. It got its accelerated approval from FDA. I think on the 7th of this month. So obviously, when FDA has approved it, that must have gone through a significant amount of clinical trial. The Aduhelm as a drug is intended to target the clearing of the beta amyloid plaques. So there is, I mean, probably definitely evidence that it is effective in clearing the beta amyloid plaques, and it might have some certain side effects and stuff like that, but which I was just generally reading from what was quoted. One thing is it will slow the progression is here, but it will not reverse the progression. This is not a medicine to reverse progression of Alzheimer's. That is, you're not going to get, if a person has a certain level of the disease, it's going to slow down the progression of the disease. And that's the purpose of the drug. It is not to treat or reverse the disease overall. That's the, I mean, and because it's just approved, and I think the US FDA is the first one to approve it as far as I know. So I think the decision is yet to be out whether how many people get it and what is the impact of it on an overall larger population is yet to be seen.
Thank you, Dr. Girish. Are there any other questions from the attendees?
I did see that there was one more. I mean, I did answer it on the chat, but it was about why only T1 3D sequence is used for MRI for measuring adiposity. So I think I had briefly answered it on the chat. It's not just the use of T1 sequence. It's the T1 sequence is probably like a very generic sequence that's a very clinical routine. So it is something that is done most commonly on a general brain acquisition, and it does have high intensity for fat region. So with a little bit of image processing, it is able to we are able to identify the regions of the fat. And additionally, we also know from NeuroShield tools and other tools that we use T1 sequence to do the volumetric measurements as well. So it sits as a good sequence for multiple measurement parameters. But I do think that other sequences such as T2 flare, diffusion do play a very significant role. So if you want to do a holistic brain exam, that would account to about maybe 20 to 30 minutes of acquisition, T1, T2, a gradient echo sequence, a diffusion sequence, and maybe like a resting state functional MR sequence. All of it put together can provide a more holistic picture. But that's the only reason why T1 was used. That it's just more accessible and easily available, more data available around there. So that was the only reason.
Anyway, T1 has to be used for dementia for the 3D volumetry.
Exactly.
So it's a bonus. One also you can think, this question also raises another idea that fat and water images of like using ideal sequence, we can actually also acquire like a 3D ideal T1 sequence and then study them together with a deconjugated. So there are a tremendous amount of opportunities as Sweta and others have, Jayaprakash, others have commented about obesity. So this is a chance for us to open our, away from dogmatism, be more open-minded, to investigate the fat as an inflammatory culprit in the body, no matter in which system it is. It is definitely in brain, it can cause microglial activation and cause neuroexcitotoxic injury or some kind of oxidative stress on the brain. And so this is known, but we need to figure it out how it will impact the exact mechanism of dementia. But before that, our studies, since we are doing volumetry studies, retrospectively, I can go back to all my volumetry studies and look at the brain fat phenomics. That is the advantage of Girish's thought process, because all skull base is included and the nape of the neck, and so there's a lot of fat included, and pinna, ears, around the ears, and the occipital fat and everything. That can be measured by ROIs and segmented the segment, and the correlation with the whole body fat also can be done, right? By using another method, if not MR, we can, if that is more cost effective, like DEXA or other body composition methods. But I prefer MR because then we'll maintain homogeneity and no variance in data, right? No asymmetry in data.
That's very nicely said, Dr. Ram. And actually, to your point, one of the continuing aspects of the study is to compare outcomes from between a T1 sequence and a Dixon sequence with water fat separation. So absolutely, I mean that's the most right fitting sort of evaluation. So I know this is a good summary that you created, that you said right now. Thanks.
We have another,
You have any other questions, Hussein?
Yes. Does field strength play a role in measuring adiposity? Would 3T give you a better resolution than a 1.5T? So could we measure possibly the adiposity better in a 3T?
No, we also should think of one is resolution, other is trade-offs, and other are fat-related problems like chemical shift artifacts. So on the 3T, the moment you cross the 1.5T boundary, fat becomes not only your friend but also a foe in creating issues, field inhomogeneities. So I think Girish will answer my question. Sorry.
I was actually going to say, I think overall fat, Dixon techniques have shown to be more reliable, and exactly as what you said, the water fat swap is more pronounced on 3T. So and also when you look at 3T, depending on the machine, if you're going with a wider bore like the 750W, I think I don't know. Like overall, if you look at the homogeneity of acquisition, there's definitely fade off at the fringes around the edges of the FOV. So if you're looking at extremity fat and over superficial fat, there is more likelihood of signal drop off. So for now, I think I mean absolutely there are fine tunings and further optimizations that can be done to obtain better outcomes from 3T. But I think so far I've seen 1.5T to be providing a better results specifically for water fat and fat estimations.
Yeah, because you have the cheese dressing on the pizza and the pizza itself. So the pizza itself is the brain, and the cheese dressing is the scalp fat. So scalp fat on 1.5T will not produce any nuisances for you. So it's a smooth story. The inside pizza is better imaged on 3T because of good SNR. So if you are combining the brain phenomics into one single data point that I want outside biomarker, fat biomarker, and also the internal intrinsic architectural biomarkers of the brain parenchyma, then we need to make all those corrections and take all those necessary tweaks so that you don't get artifacts and do a good job. But everything is being managed by automatic deep learning based corrections, and so that won't be a problem in future.
Yeah.
Thank you, Dr. Valapari and Dr. Girish.
Please call me Ram. Okay. Please call me Dr. Ram.
Dr. Ram.
Valapari is a stranger to me.
Okay.
Okay. Thank you.
Do we have any other questions from the audience?
Fantastic audience. They have stimulated my head today. And especially Jayaprakash, Sweta, and others asked some very, very wacky, beautiful, and Aarti also. And very interesting. This is what a discussion is. I am very happy that you invited me, and I learned a lot. Thank you, Girish. Thank you, Rajesh. Thank you, Hussein. And thank you, whole team of NeuroShield. And thank you, ladies and gentlemen. Bye-bye.
Yeah.
Thank all the panelists.
Yeah, I just want to thank the entire setup here, as well as everybody who really made this possible for the opportunity. I think it's definitely, as Dr. Ram said, a very lively discussion, nice question. So, thanks for that.
I would like to add that we are grateful for all the panelists for taking out their time and joining us today, as well as our attendees. And a video recording of this will be shared with you, along with the video recording of the previous session, in case you missed that. And thank you so much, and we'll see you next time.